Hello everyone, my name is Dr. Joel Rosen and I am a spinal decompression master. And so what I wanted to do is I wanted to talk to you about spinal decompression, specifically using the DRX 9000. That's what we're looking at right now. We have both the neck unit and the lower back unit. So these are for patients that suffer with herniated discs, musculoskeletal injuries, numbness, tingling, radiating pain down the arms or down the legs, positive MRIs that may have shown bulging discs or degenerative disc disease, spinal stenosis. They're candidates for surgery. They've done epidurals, or they're told that they need to do epidurals. They've gone for physical therapy. They've gone for chiropractic care. They've gone for pain management, and they're still suffering. So they're looking for another solution. So what does the spinal decompression do? Basically, the spinal decompression is a non-invasive way to help patients that suffer with these herniated discs. What does it do? Well, basically, if we get this trusted spine model over here, what we're doing is for the lower back, we're able to pull up to half the person's body weight off of their lower back. And what's great about it is we can angle the machine so that it focuses on a specific level. So that's why it's very, very important to have an MRI, because we go through a three-step process. The first step whenever we're considering someone for a candidate for the care is, number one, understand what's their condition, what's going on. There's no better gold standard than a MRI. So I will put patients on the machine if I do a very, very good workup and I don't have an MRI at my disposal, or we'll do an X-ray. But at the very least, we have to do a proper workup. Nothing better than an MRI. Once we look at the MRI, we understand the extent of the condition, whether it's a bulging disc or a herniated disc or multiple degenerative discs, if there is any slippage forward on the spine, if there is any stenosis or encroachment. We understand all of those things, then we can get a better idea as to what the prognosis is going to be. So step one is gold standard. What's going on? What's the MRI say, and what have you been through? What are you doing that you can't do? When did it first start? Do you have numbness, tingling, radiating pain down the legs? What are the activities that you can't do? What are the activities that make it worse or better? It's very, very important to know all those things. What are the things that you're not doing in your life? Are you not able to go out and walk, or go for a long drive, or play with your kids or your grandchildren, or go on vacation, or sit down in an airplane? Those are things that we need to fix. Second step is what, based on the diagnosis from the MRI, are there any reasons to not go on the machine? The first one typically is going to be a fusion. So having screws, rods, pedicle, plates, all these type of things are typically a non-reason to go on there. I say typically because there are patients that do go on the decompression DRX 9000 machine in different offices. That would be a case-by-case scenario. We'd need to see the extent of the injuries. And in these cases, we do need to see imaging. It's hard to do MRIs now that there's hardware, but typically you can see CT scans and X-rays to get an idea as to what the pathology is. Number two, is there a spondylolisthesis? That's when one of the bones slips forward on another bone. So when we're looking at these bones from the side, we want to see if one bone is slipped forward or behind another bone. If there is, then typically nothing greater than a grade 2, meaning the bone slips half the distance versus 3/4 of the distance on the bone underneath it. Then if it's a grade 2 or less, we can put you on there. And then lastly, the third contraindication or reason to not go on the machine is any abdominal dissecting aortic aneurysm. And typically we don't see these patients in our office. These people are surgical candidates. They know about this problem from a cardiovascular event or a heart attack or a stroke, or being grossly overweight and having arterial sclerosis. These are problems that we typically don't see. Once we clear you of these problems, I've had patients that have had hip replacements or knee replacements or shoulder replacements. That's fine. We can put you on the table. Once we clear you of these contraindications, then it comes down to the third step as to what to expect, how long does it take, how much money does it cost. The first thing I'll tell patients is what to expect. Depending on if your pain is radiating away from your leg, then what you're expecting is what's called irradiating towards the spine. That's an outcome where we look at as a positive outcome, meaning it's a peripheralization of the pain, and now it's a centralization of the pain. We do really, really great stuff with that. Also looking at filling out an Oswestry score to see your disability index and getting an idea as to what you're starting with from an objective point of view and what we're going to be able to get you. So pain, being able to sit, being able to lift, being able to do your activities, being able to do your life. We can measure where you're starting with and where you're going. That's an objective measure that we do. How long does it take? Typically, we recommend anywhere between 4 to 6 weeks. It could be twice a week or it could be 3 days a week. We're looking to get you in the 12 to 20 range of a half an hour treatment. How much does it cost? It really depends, depending on if you have insurance, if you've been in a car accident, if it's a workers' comp injury. We don't take too many insurances these days because insurance simply doesn't pay what the machine is worth. So what we do is we have a special discounted plan depending on what your insurance does cover, and we minus that from what our costs are. And you're looking at somewhere between $50 to $120 per visit. That's the ballpark typically you're looking at. But what I got to ask you is, how much is your pain worth? If you're not able to get up in the morning, or you're in tears, or you can't put on your shoes and socks, or you can't sit down, or you can't go to work, then what is that worth to you? Is it worth you getting better? I have a whole host of testimonials that you can find on my website, and those are all patients that were skeptical just like you, and they did really, really well. So what does the machine do? Is it long lasting? Is that one of the questions that I get a lot of the time? And what I got to tell you is basically it takes up to half your body weight off your lower back, and it takes 10% of your pressure off your neck. By doing that, it creates a negative suction in the disc. So it infiltrates the disc with fluid. When it infiltrates the disc with fluid, what's happening is that fluid is getting vital nutrients in way of oxygen and glucose and reparative immune cells that's allowing that disc to regenerate itself. When it regenerates itself, it puts the pressure away from the one above it and the one below it, and it's able to rebuild and recuperate. So typically when I have a patient on here, I don't see them after because they do very, very well, but my suggestion to them is anywhere between the next 6 to 8 months, let's get you on there daily for the next week, or let's get you on there for a couple days for the month, and we can rehydrate you. Hopefully this spinal decompression video answered a lot of questions on how it works, and we look forward to helping any one of you guys that are suffering. Just check out my video on my website below and you can get more information. Thank you so much.